How do you recognize and manage immune-mediated nephritis? Immune-mediated nephritis is seen in approximately 1% of patients on checkpoint inhibitor therapy. The median time to onset is variable, approximately 6 to 30 weeks, and usually around 3 months. Most of the time, patients are asymptomatic, and this is picked up on routine blood tests, so it's important to monitor the creatinine level prior to every infusion. If the creatinine is elevated, there can be many other causes of acute kidney injury, such as dehydration, recent IV contrast, urinary tract infection, other nephrotoxic drugs such as NSAIDs or diuretics. And so it's important to rule out other causes before treating for immune-mediated nephritis. If no other causes are found, then the patient can be treated. A grade 1 nephritis is a creatinine 1.5 to 2 over baseline, or an increase of 0.3 milligrams per deciliter. And in this situation, it's recommended that you hold the immune checkpoint inhibitor to rule out other etiologies, limit or discontinue any other nephrotoxic medications, and repeat the creatinine every 3 to 7 days. If it continues to worsen or it becomes a grade 2, which is 2 to 3 times greater than baseline, you hold the immune checkpoint inhibitor and start steroids. You can start prednisone orally, 0.5 milligrams to 1 milligram per kilogram per day, and continue to check the creatinine every 3 to 7 days. If it starts improving on the steroids, you can taper over at least 3 weeks. If there's no improvement, you should increase the steroid dose or add an additional immunosuppressant. For severe cases of grade 3 to 4 toxicity, which is more than 3 times the baseline creatinine, the immune checkpoint inhibitor is discontinued and steroids 1 to 2 milligram per kilogram per day are started. At this point, you may consider consulting nephrology, and if there's no improvement in 3 to 5 days, consider additional immunosuppression such as mycophenolate mofetil, azathioprine, or infliximab.